One slide on the screen.
Just one slide.
Okay, fantastic. Okay, guys. So, so tonight we're going to be discussing, of course, your teaching program says pelvis and acetabulum fractures, and I'm sure you will all appreciate that we can't discuss everything in one evening. So, we're going to be doing emergency management of pelvis ring injuries. And even before we start, we had this discussion in theater. So I was in theater with Waziba and Lydia this afternoon, and we're talking about this book. I don't know how many of you have read it, but it's one of those old, self-help style kind of books. So it gives you, the 7 habits of highly effective people. And one of those habits is that when you begin a task, you must have the end in mind. So I've taken inspiration from this. And so basically, I want to give you 7 take-home messages. And that's take-home message number 1, message number 2, number 3, 4, 5, 6, and take-home message number 7. So anyone, what's the take-home message?
Pelvic binders.
Pelvic binders.
Yes. Okay, great. So that's a take-home message. Pelvis binders save lives. I mean, many of you may work in institutions or have come from institutions where, people will still ask for the pelvis X fix. And the message for tonight is that there is no place for the X fix in the emergency setting. So any patient that comes in with a bleeding pelvis fracture that needs to be stabilized gets a pelvis binder in the trauma unit, not an external fixator. And so basically the overall clinical pathway that you are looking, or at least that you're going to be faced with, is that firstly, you need to recognize instability. And by instability, as we're going to see later on, we refer to both skeletal and hemodynamic instability. Then you need to identify the sources of bleeding. And these can be both intra and extra pelvic. And importantly, you need to stop the bleeding. And a couple of ways you can do this. You can do direct control of the vessels. If, for example, they're bleeding from the external iliac vessels, you can do angiography if they're bleeding from the branches of the internal iliac vessels. And there's an opportunity for pelvis packing in patients who come in either unstable or in extremis. And it's only once you've taken care of the acute presentation and the acute hemorrhage and the patient is stable, then you look at definitive treatment of any other injuries that are associated, including the pelvis fractures. So typically, this is the kind of patient you're going to get, and it's certainly, I'm pretty sure it's the same in every other hospital, that we're seeing this sudden increase in patients who come in and are, Uber Eats or domestic delivery or Checkers 60 or Checkers whatever 360. But basically, they're not used to riding motorcycles. And importantly, our drivers are not used to having so many motorcyclists on the road. So these guys get knocked over left, right, and center. And, luckily for many of them, because it's all low velocity motorcycles, they don't really present with major polytraumatized injuries, unlike the real, superbike or motorbike enthusiasts who ride fast and a bit more reckless. But occasionally you will see like a complex patient from Uber Eats. So it's often high energy and often polytraumatized with lots of other injuries. So the classic presentation you're going to get is that the paramedics will push this guy into the resus bay, and he comes in intubated, he's hypotensive, he's tachycardic, and then they say, oh, he also has a mobile pelvis, his abdomen is tender, and lastly, he is not responding to intravenous fluids. So in a guy like this, it's a lot of complex issues to deal with. So you need to be able to break this down into small chunks that you're able to deal with. So the main question here, or rather the main presentation here, is that this guy is bleeding and we need to stop the bleeding. That's the primary goal. But of course, often it's easier said than done. You know, where is he bleeding from? You know, is it, we see he's got a chest drain, he's got a huge wound in his thigh, he's got distended scrotum, his tummy is distended. So it's never easy to tell what the actual bleeding source is. So what you think about the potential bleeding source? Let's just go back to anatomy of the pelvis. So you remember that the pelvis is basically mostly a bony structure. It's got the two innominate bones on the left and the right, and it's joined posteriorly at the pubic symphysis, anteriorly at the symphysis and posteriorly with the sacrum via the two sacroiliac joints. But of course, the bony structure on its own has no intrinsic stability, so it relies on ligaments for stability. And here we've got the anterior sacroiliac ligaments, we've got the pubic symphysis ligament, but posteriorly, and more importantly, we have the sacrospinous and sacrotuberous ligaments. And these ligaments are some of the strongest ligaments in the body. So the implication being that it takes massive forces to disrupt your pelvis ring. And sometimes, even if it does get displaced at the time of injury, because of the recoil nature of the ligaments, it will tend to spring back into what appears to be a more innocuous lesion, despite the displacement at the time of injury. So over and above the ligaments, we also have the muscles, which contribute to stability. But of course, the addition of muscles now contributes to the addition of bleeding sources. And then for bleeding sources, we've got the arteries. Now, depending on where the lesion is on the arteries, it's going to determine how the patient presents clinically. And often there are four presentations. Patients will present with hemodynamic stability. You'll get patients who present with hemodynamic instability, but they respond immediately to treatment and they remain stable. Then the third category is patients that we call transient responders. And those are the ones who present in hypodynamic or hypovolemic shock. But once you resuscitate them and you give them blood products and you stabilize the pelvis, then the blood pressure improves. And then they are stable, but only for a while. And then a couple of minutes later, they crash again. So those are called transient responders. And then lastly, we have the ones who present in extremis. And then I'll just go quickly through where each of those patients is often bleeding from. So we'll come to that. And then over and above the arteries, we have the veins. And so with the venous system, it's mostly the sacral plexus that matters more for instability. But of course, you've got patients who can come in bleeding from the either internal or external iliac veins, but that's quite unusual. So if we come to the anatomy, and importantly the mathematics of the anatomy, so the pelvis is basically represented to be like a truncated cone. And for the mathematicians amongst you, that's the volume of a truncated cone. So the importance of this is that, any increase in, either radius 1 or radius 2 will increase your pelvis volume disproportionately, but an increase in height, which is your vertical instability, will disproportionately increase your pelvis volume. To such an extent that any 5 centimeter diastasis in your pubis will increase the pelvic volume by up to 20%. So when these patients present to you, there's a couple of questions you need to ask yourself. So first question is the pelvis ring broken? Yes or no? If it's broken, is it stable or unstable? And if there's a bleeding source, is the bleeding source intrapelvic or extrapelvic? And what are the associated injuries? Unfortunately, when it comes to decision-making for these patients, you don't often have the luxury of time. So you need to act with urgency. So first question, is there an unstable pelvis fracture? So here you often rely on radiographs, and many times by the time the patient gets referred to you, they would have had the initial AP X-ray, which is what you have on the left of the screen. That's an obvious, disruption of the pubic symphysis and the sacroiliac joints, and it's an easy diagnosis to make. But beware of the patient on the right. So in this patient, the pubic diastasis doesn't look excessively wide, and but if you look at the level of the left and right pubic rama, you can see the one on the left is higher. If you look at the sacroiliac joints, the sacroiliac joint is more open on the left, and also if you look at the lesser trochanter of the femur, it's more pronounced on the left. So it means that the entire hemipelvis on the left is actually disrupted both anteriorly and posteriorly, and that is a far more unstable injury than the one on the X-ray on the left. So also if you look at the obturator foramina, if you compare the two, so basically the left hemipelvis is rotated externally. These are the patients that are often misdiagnosed and not well appreciated that they have an unstable pelvis injury, so look out for them. So that's what the X-rays will tell you. And then clinically, is there an unstable pelvis fracture? Now, many of the older texts will talk about the pelvis rock maneuver. That's when you basically put your palms on the anterior superior iliac spine or the iliac wing on both sides and push down, posteriorly. If it opens up, then it means it's unstable. Or if there's no movement when you push down, then you put your hands on the outside of the iliac wing and try and close it and see if there's any movement. Now, this is something we don't recommend anymore. And also because these are extremely unusual injuries, chances are, if you're lucky, you will see one or two in your lifetime if you don't work, permanently in trauma like I do. So when these patients come, many people who are on call that night will not have seen an unstable pelvis fracture patient primarily. Now, if everyone does the pelvis rock maneuver just so they can, practice or see how it works, these patients come in, in hemodynamic instability, but they also have a coagulopathy. So if you keep doing the pelvis rock maneuver, you're going to dislodge the clots that they have formed. And because they are hypothermic, they are acidotic, and they are coagulopathic, they're not able to form any further clots, and they can bleed to death. Hence the statement that the first clot is the best clot. So leave it there, don't dislodge it. And then the concept of stability refers to both hemodynamic and skeletal stability. And so when we go to bleeding sources, so I said this could be intrapelvic or extrapelvic. If they're extrapelvic, it could be from the abdomen, could be from the chest, or you may be lucky that you see an obvious external wound. But now let's go back to intrapelvic sources of bleeding. So we spoke about these just earlier on. So you can have patients bleeding from large named vessels. So often those patients firstly will present in extremis, and they're bleeding either from the common iliac vessels or the internal or external iliac. These are extremely unusual, and the patients who have an injury to these vessels will present in extremis. Many of them will not make it to hospital. They'll die on the scene or en route to hospital. And the ones that do make it to hospital, the only way to stop the bleeding is by laparotomy and direct control of the vessel by clamping them. There's no other method for them. Then we go to the smaller named vessels. Now, those are often branches of the internal iliac artery, your superior and inferior gluteal, your obturator vessels. So these are the patients who present with hemodynamic instability, and we call them transient responders because they're bleeding from the smaller vessels, like I said. And if you close the pelvis with the pelvis binder and you give them fluids, you give them blood, they will respond. But unfortunately, most of those mechanisms don't directly address small arterial bleeding. And as they continue bleeding, then the blood pressure crashes again. And then we give them fluids and they respond again. And then they crash again a few minutes later. So they're called transient responders. Then the next category is patients who are bleeding from unnamed vessels. Now, those are often venous plexuses around the sacrum. As you know, your pelvis is very well vascularized. Now, these patients present in two ways. If they've bled out, they'll present hemodynamically unstable, but because it's from a lower pressure system, which is a venous system, once you stabilize them, and once you resuscitate them, stabilize the pelvis with a binder, the blood pressure will pick up and it stays up. So they respond well to resuscitation. And then lastly, patients will present with bleeding from the fracture surfaces. And because your pelvis bone is a bit of a hybrid between cancellous and cortical bone, and it's very well vascularized. And again, these patients will respond to resuscitation and once you've stabilized the pelvis. So what is the primary aim? Like I said, primary aim is to stabilize the pelvis and you need to stop the bleeding. Now, many people are familiar with how to stop bleeding from the abdomen or from the chest or from the obvious external wound if there's one. But very few people are familiar with stopping bleeding from the pelvis fracture. Hence the statement here from Marvin Tyler that what is good for the fracture is good for the patient. So if you control bleeding from the pelvis ring, that will help, save your patient's lives. And traditionally, when you look at the textbooks, they'll talk about military anti-shock trousers. They'll talk about external fixators, but those have no place in modern resuscitative medicine. There's two things that you need, or rather there's one thing that you need, and that is to circumferentially close your pelvis to reduce the pelvis volume. Now, there are elegant ways of doing this, or there are ways which are not so elegant, but extremely functional. So if you take a bed sheet, for example, if you roll it up nicely, you can wrap the sheet around the pelvis and use clamps to control the pelvis bleeding. If you don't have, or rather, if you're lucky enough to have access to commercially available pelvis binders, then you use a pelvis binder. Those are the only two things that will work in the acute setting. And many hospitals are fortunate enough to have access to pelvis binders. Many paramedics in the ambulances have pelvis binders. But if you don't have a pelvis binder, then you use a bed sheet. And that's what it looks like. So if you use a bed sheet. So the pelvis binders we use look like this. So there's the middle strap, which is over the trochanters. Then you've got the lower strap and the upper strap. And these are Velcro straps. And this is very soft material at the back, which removes your concerns about pressure sores. And the beauty about this is that as long as your middle strap over the trochanter is applied, you have access to the abdomen if you need to do a laparotomy. You have access to the femoral vessels if you need to do an angiography and embolization, but the pelvis remains immobilized. So what are the advantages of the pelvis binder? Firstly, it is easy to apply, unlike an X-Fix. And importantly, it can be applied in a pre-hospital setting. So I'm sure you'll know that many patients who come through to our trauma units will have a pelvis binder applied by the paramedics if there's any concern of a pelvis fracture. And our teaching to them is that, if in doubt, apply the pelvis binder. We can always take it off if it's not required. But if you don't put it on and it was required, that's one life that you'll never bring back. So they apply it liberally. And there's no need for theater for the pelvis binder. And there's no requirement for an orthopedic surgeon to be present, unlike an X-Fix. And also, because, when you're on call for orthopedics, most of the time you do the call from home. You don't do the call from the hospital, so you're not immediately available in the trauma unit. And also, the other concern is that if you have like the so-called, lateral compression fracture with an internal rotation component, if you apply a pelvis binder, will you not make that fracture worse? The answer is yes, you may make it worse, but we can fix that easily, And of course, if the pelvis is rotated internally, that helps to reduce the volume and whenever the binder is no longer required, we'll simply remove it, without causing any harm. So you just need to be liberal with the application. And it's been the biggest change in trauma resuscitation over the last couple of years that you apply the binder to everyone, and it's been shown to reduce the length of stay, it reduces blood transfusion requirements, and it reduces mortality. And then the other thing is just be careful that, many a time, the first X-ray that you're going to get is going to be taken with a binder in place. So in that instance, you must keep the binder on until the patient is stable. Then you can take the pelvis binder off and take what's called a binder off X-ray to see what's going on. So typically that's what you're going to get, and just with applying a binder only, that's going to be the result that you get. But like I said, many a time the binder will be in place already when you have the first X-ray taken, so be mindful of that, and remember to take, if there's any doubt, to take a binder off X-rays. But in a case like this, even with the binder on, you can still see that there's pubic diastasis, and this guy is going to need further intervention. Of course, like everything else, the pelvis binder only works when it's applied properly. Like I said to you, that's how it's meant to be applied, with the yellow strap or the middle strap, overlying the trochanter. What you find is that if it stays for long enough in the hospital, then it tends to migrate, and it becomes far less efficient. Patients go to the trauma wards, patients go to ICU, so you need to keep an eye on that. And the nurses will turn the patient to the side to clean them, and the pelvis binder can lose position. One of the questions I get is that, are there no concerns about pressure sores, and how long do you keep the binder for? So like I said, the pelvis binder that we have is got a very sort of soft neoprene material that protects the bony prominences and the sacrum. And so we basically apply the binder until the patient goes to the next available theater. It's often quick enough. And the only time we remove the binder for an X-fix is if a patient needs a laparotomy. So if someone gets a laparotomy, then the binder gets removed and they get an X-fix. But any patient who does not need a laparotomy and only had a pelvis ring instability, we keep the binder on until they go to theater, and that will be between, or up to about 7 days, but we try and prioritize them so we don't have a pressure sore problem. And lastly, again, if you keep the binder for long enough, it keeps migrating northwards, and this one is almost a boob tube. And then the other thing that you can do, because of the natural anteversion of your femur neck, if your pubic symphysis is disrupted, then you lose that hinge in the middle of your pelvis, and the femur anteversion will displace your pubic symphysis even further. So the X-ray on your left compared to the one on your right, the one on the left, there's no pelvis binder on. It's just that the legs are left in external rotation. But if you rotate the legs internally and you tie them together, you get the X-ray on your right. So this is also another way to assist with your resuscitation. And in patients who have a vertical shear component, it's very difficult to control that except with an external fixator. With skeletal traction, and you put this in the proximal tibia. We'll talk about X-fixes briefly. So traditionally, it's the anterior X-fix that's been used, and this goes into the iliac wing. Now the difficulty here is that it is firstly far less stable than the so-called supraacetabular X-fix, and so in its favor is that it's easier to apply, but it has less stability. And because it's an anterior X-fix, when you close the X-fix and you put your bars and you tighten them, it'll close the front, but so often it opens the back, which is where most of the problems come from. So the one that we use is the anterior to posterior, or the supraacetabular X-fix. This is far more stable, and basically it goes from the anterior inferior iliac spine all the way down to the back of your iliac wing. So it gives you almost global coverage of your pelvis. And as you can see from the construction of the frame, that you need far more clamps and bars with the anterior X-fix, whereas the suprastable X-fix, one pin on each side, or one shunt pin on each side is sufficient. And then in some cases, very infrequently, you may need to use a C-clamp. It's not something that we use often. We have it at Hodeskia, and I use it mostly for reduction of the SI joint in theater more than we use it for acute resuscitation. But in some instances, they will talk about the C-clamp. Does it have a place? Yes, it does. If they say once you have applied your pelvis binder and you still have ongoing bleeding, which is very unusual, then there's an opportunity to use the C-clamp to close your pelvis posteriorly, but it's very unusual. So like I said, for me, just a picture on the top right, that's how I use it, mostly in theater, to just reduce the SI joint if I'm planning to do an SI screw. So do the C-clamp and then do an SI screw, and then C-clamp comes out. So what will the X-fix control? Because it stops movement and affects some kind of tamponade, it will control bleeding from the cancellous bone surfaces. Because it, to some extent, also, stops movement of your pelvis and affects a little bit of volume control, it'll stop bleeding from the venous plexus, which is a low pressure system. But if you have arterial bleeding, it will not control arterial bleeding. And the other downsides to it are that it is specialized equipment. Like I said, it requires orthopedic expertise. And for it to be applied safely, the patient needs to be transferred to theater. And sometimes patients are too sick to transfer to theater. And if you're applying it blindly and there's an associated iliac wing fracture, you can actually cause more damage with the X-fix. And also beware of misplacements if you're doing it blindly, into the hip joint or into the pelvis. So to emphasize again, we don't do this in the acute setting. So now we come to our algorithm. So now, why do we have an algorithm? You get many people who are against algorithms, and they believe that they discourage people from thinking. But the reality is that when it comes to patients with an unstable pelvis fracture who present in hemodynamic instability, that's a very unusual combination. And chances are the junior staff that are on call that night will be dealing with a patient like that for the first time. So they have no experience to draw upon, which is why it's important to have an algorithm. And also the beauty with an algorithm is that if everyone applies it religiously and to the T, if you have poor outcomes, you're able to go to algorithm and change one thing at a time until you get the desired outcome. But if every night everyone does something different and your outcomes are poor, you've got no idea where to start, if you want to improve things. So the same principle goes with many things that we do in orthopedics. For example, I'll make an example with our distal femur locking plates, where we saw lots of failures initially because people were applying them in different ways. Like you would have near, far, near, far, near, locking screws, no locking screws, and many were failing. And of course, once we wanted to address the problem, we didn't know where to start. And the best place to start, like I said, is to standardize the practice. So have everyone do the same thing. And then from there, you can then, discuss and make your improvement. And hopefully we'll have the discussion on distal femur fractures at some point. So anyway, back to our Hodeskia algorithm. So you're going to be presented with a patient with an unstable pelvis fracture. So the first question to ask is you're going to look at the hemodynamic status. And they're going to be stable or unstable. Remember that this is a patient with an unstable pelvic fracture that you've seen on the X-ray. Now you look at the hemodynamic status, and like I said, they'll be stable or unstable hemodynamically. If they're stable, then that's fine. You've got time. You can complete your secondary survey. And because they are stable, a pelvis binder is not necessary, but we always say it's safer to put it on until you're happy that it's not required. So they still get a binder. We complete the secondary survey, they get their CT scan, anything that they need to get, they get. And you also treat whatever else needs to be treated. But once they are stable and ready for surgery, then we'll do definitive fracture management. Now, what about a patient with an unstable pelvis fracture who presents in hemodynamic instability? Those, you apply the binder again and you resuscitate with blood and fluid and whatever ratio is required. So in these patients, you know that they have an existing unstable pelvis fracture. You've got the pelvis binder applied. So momentarily, you can forget about the pelvis and look at other potential bleeding sources. Could they be bleeding from the abdomen, from the chest, or is there an obvious wound? So the only way to do that is to do CT scan. You do ultrasound if that's what you do. You do your obvious clinical examinations, but keeping in mind that the resuscitation doesn't stop. So all your efforts continue with your resuscitation. If you want to send the patient for a CT scan, that's fine. You will have a window to scan them. So resuscitate them, let the blood pressure go up. Once it's up, then you go to CT and then back to the resuscitation bay. So they give you an opportunity to investigate. And then if there's an obvious bleeding source, which is an abdomen or chest or any other wound, then you have to manage that specific problem, either with a laparotomy or a thoracotomy and obvious wound management. And if they go to theater for a laparotomy, those are patients who then get an external fixator, only once they're in theater, because from theater, they're going to go to ICU. And we've seen what happens to pelvis binders in ICU. And also, they're going to want to go back to theater for relook laparotomies. So in theater, stable, controlled environment, we can then swap the pelvis binder for an X-fix. And then when they're stable, you then remove the X-fix and do definitive fracture management. But now what happens in a patient with hemodynamic instability, an unstable pelvis fracture, but all your other investigations are negative? There's no bleeding from the abdomen, there's no chest bleeding, and there's no obvious wound. So in these patients, it's then obvious that the only bleeding source is the pelvis. And for them, we then do angiography. So they get angiography and we embolize. And once they've got angio and embolization and they are well controlled, no longer bleeding, then we'll do definitive fracture management. I'm going to talk a bit about angiography a bit later because not everyone has access to angiography. And of course, keeping in mind that some of these patients will present with open fractures. And if there's an open fracture, then the other rules apply, like sterile dressings and tetanus toxoid antibiotics, manage the wound. And if they need a defunctioning colostomy, then that's what they get. Now, what about a patient who presents in extremis? So they come to trauma and they just don't respond to any kind of resuscitation, and they also have an unstable pelvis fracture. So those patients get a pelvis binder and they go straight to theater. There's no time for anything else. Then they will get a laparotomy and then control the intra-abdominal bleeding source. Then they get an X-fix. Then if at laparotomy they have a pelvic hematoma, which means they're bleeding from the pelvis, then we do pelvic packing. And then of course, pelvic packing really only works well for arterial bleeding from the smaller named vessels, like the superior or inferior cruciate vessels. And so if the bleeding is from those vessels, then we still do angiography, but only after the patient has been stable enough and we've got the pelvis packing in place, then they go for angiography. However, if there's no obvious pelvis hematoma, because they came in extremis, we're still a bit concerned. And once again, once they're stable enough, we'll send them for angiography to rule out any other smaller named vessel bleeding. And then when they're stable, then they'll get definitive fracture fixation. So what does angiography look like? So this is angiography. Remember we said this is your common iliac artery. That's your external iliac and that's your internal iliac artery. And you can see the contrast blush or extravasation. It's almost always from the smaller vessels, from the smaller named vessels of the internal iliac vessel. And once you've isolated it and you see where it's coming from, then you're able to just put a coil. So it's directed only to that one bleeding vessel, unlike clamping, which, so it's very difficult to clamp the smaller vessels. So if you were to clamp, then you would clamp the internal iliac artery and affect other muscles. So this is now when you do packing, often we do so this patient are going to be unstable, so you need to have an X-fix in place first, so you can have something to pack against. So we take them to theater, do the X-fix, and then pelvis packing. And pelvis packing really is infravesical and extraperitoneal. So it's often the patients will have a laparotomy incision, and all you do is put packs on the side. So through the it's called the retropubic space of Retzius. On the one side, push as many swabs as you can to the left and as many swabs as you can to the right, up until you can put any further swabs in. And that's how you do pelvis packing. And then they close the abdomen and your patient goes to ICU to recover. Now, there's a lot of discussion, between angiography and packing, which one is better. And the truth is that, they're both effective depending on your clinical scenario and clinical setting. Those who have access to angiography swear by angiography, and those who have no access to angiography will say packing is just as good. So we looked at our own stats at Hodesky, where we looked at the angiography, because the difficulty with angiography is that it needs to be, the people who are on call for the angio suite don't do the call from home. From the hospital, they stay at home. So you must call them out, and then they must switch on the angio suite, get the machines to warm up. So it takes a long time for the suite to be ready. And so we looked at our patients who presented with unstable pelvis fractures over a 15-year period. And the average time to laparotomy was 4.5 hours, but average time to angio is 14 hours. And 4 hours being the best case scenario where someone comes in during the day and the whole team is there. But angiography does delay your time to intervention. And unfortunately, if you look at the literature, at the moment, you will see far more articles on pelvis angiography versus, pelvis packing. So unfortunately, it is certainly in the places that we practice in, it's becoming a lost skill, but definitely there's a place for pelvis packing. So now here, what it says is that if you look at the fracture, just forgive the many words on the slide, but basically it talks about the importance of the fracture pattern in deciding where the patient is bleeding from. So if a patient is an AP pelvis and they have a stable fracture pattern on the X-ray and they present in hemodynamic instability, 85% of the time, those patients will be bleeding from the abdomen only and not from the pelvis. But if you have an unstable fracture pattern and the patient has hemodynamic instability, 1/3 roughly will be bleeding from the abdomen, 1/3 from the pelvis, and 1/3 from both sources. So you just need to be prepared for that. So this is an example that if someone presents with this X-ray, it's got superior and inferior pubic rami bilaterally. If this person presents with hemodynamic instability, you can almost bet your bottom dollar that the pelvis here is not the problem. So they're going to be looking elsewhere for the bleeding. But the other patient I spoke about, where 1/3 will bleed from the pelvis and 1/3 from the pelvis, from the abdomen, and the other 1/3 will bleed from both sources. So if a patient like this comes and they present in extremis, it's very difficult to know what the culprit is. Is it the pelvis? Is it the abdomen? Is it the chest? And if you move to your right, that's a combination of a acetabulum fracture and a pelvis ring fracture. And this is often referred to as the killer combo or the killing combination of a pelvis fracture and an acetabulum fracture. So those patients will present with hemodynamic instability. And it's, like I said, it's difficult to tell exactly where they're bleeding from. Okay, so to summarize, if a patient comes in with your AP pelvis looking like that, you apply the pelvis binder and this buys you time and it saves your patient's life, and you have enough time to do your investigations, and only once you're happy do you then go for surgical fixation. And so to go back to our take-home message, that pelvis binders save lives. There is no place for X-fix in the resuscitative acute phase. And that brings us to the end of our presentation, of the presentation. Okay, so now I'm ready to take any questions or comments.
Prof, I've got a question that always bugged me about this. I hear the message about pelvic binders saving lives, but there are some fracture patterns of the pelvis where applying a binder might actually cause more injury to the patient. So the pelvic fractures which are unstable with external and internal rotation. If you like the lateral compression injuries where putting a binder on might actually distract the posterior elements more.
So putting a binder does not disrupt the posterior elements. Remember, the binder gives you 360 coverage, circumferential coverage. So if you've got your patient lying on the binder, when you tighten it in front, the whole pelvis gets squashed together. So it never opens the back. But what it does do sometimes is that it may close in the front like that. So in the lateral compression, it'll make the lateral compression, it'll make it worse, I agree. But when you make the lateral compression fracture worse, what do you risk in terms of patient life? You don't, because you are decreasing the pelvis volume. So you're making it worse, and that's something that we can easily undo by removing the binder when it's safe, or we can fix the fracture when it's time to fix, but the pelvis volume remains reduced. So whereas if you had a patient who needed a binder, but you did not apply it, that's something we can never undo, So whereas if you apply it in a patient who didn't need it, fine, you may displace fractures, but you will also save lots of lives. And then if it's not required, we simply remove it or simply take it off. So the message here is that if you're in doubt, just apply the binder and then we'll remove it. So you'll see when you come across to orthopedic that many patients, by the time you see them, they've had the Lodox, but the binder is in place already. And that's certainly our teaching.
Okay, cool, thanks.
Thanks. Any other questions? Comments? So maybe by show of hands, in the last, let's say 3 months, how many of you have had to deal with a patient with an unstable pelvis fracture who presented in hemodynamic instability or with hemodynamic instability?
Not in the last 3 months, but in the last year, yeah.
In the last year. So is anyone else? So, I mean, that's basically, that's the point I wanted to make, that these are very unusual injuries, and that's why it's important to have a treatment plan in mind. That's why it's important to have an algorithm to guide the decision making. Otherwise, it's just going to be total chaos when everyone else does things, in their own way, and there's no uniform protocol.